Presentation 19 GIT for biliary system, prepared by Prof. Sharaf, revised by Prof. Hani Sami. Here is the appearance of biliary gas. Here is a normal MRCP, MR cholangiography in a patient with suspected pancreatitis. Common bile duct anomalies: number A, right lobe branch inserted into cystic duct. This one inserted into cystic duct. B, right lobe branch inserted into hepatic duct. B, into hepatic duct. C, right lobe branch inserted into left lobe duct, main left duct. D, short cystic duct inserted close to the porta hepatis high up. In such a setting, the common bile duct is readily confused with cystic duct. Percutaneous cholangiogram. This is the needle. Numerous cavities communicating with irregular bile ducts. This is a case of biliary atresia in a newborn and has to undergo surgery. Type 1 colloidal cyst involving the hepatic duct. This is right branches, left branches, common hepatic, common bile. It is involving the common hepatic duct. Colloidococele, dilated distal end of the common bile duct, indenting the ascending duodenum. Here it is. And this is the duodenum. Contrast filled duodenum indented by this colloidococele of the common bile duct. Fluid level within the gallbladder, denoting some blood, and if 3 levels, this will denote the presence of mud. Obstruction of the cystic duct with a stone, showing the meniscus sign, and there is fistula after cholecystocutaneous fistula after cholecystectomy. This is the stone at the common bile duct. Here is extravasated contrast after lab coli. Water soluble contrast was used. This is not barium, and there is definite perforation of the duodenum. Here, blown up cystic stump. This should be the cystic stump, should be closed. Here it is blown up. The resultant biloma was drained percutaneously. Percutaneous cholangiography in a patient with jaundice after lab coli. There is complete obstruction of the common bile duct. Same appearance as Klatskin tumor. Here is the intrahepatic biliary dilatation, how it appears in the CT, and this is Klatskin tumor with dilated intrahepatic biliary radicals. This is afferent lobe obstructed, and this resulted all of this. and this resulted in cholangitis. The intrahepatic biliary radicals appear normal. Cholangiohepatitis due to multiple stones within the dilated intrahepatic bile ducts within the liver. This is of course less common than to be extrahepatic, and there is definite multiple ill-defined outlined biliary radicals denoting diffuse hepatitis, cholangiohepatitis. A gallbladder is converted to an abscess, and this was drained percutaneously. This is emphysematous cholecystitis, where air is formed within the wall and inside the lumen, and this is the appearance of emphysematous cholecystitis, gas in the lumen and the wall. Ascarids in the common biliary duct, common bile duct ascariasis. Irregular diverticular-like outpouching. Irregular diverticular-like outpouching or beading. Segments of narrowing and alternating with segments of dilatation. This is a characteristic finding of the sclerosing cholangitis. Recurrent cholangitis with multiple abscess-like formation, ill-defined outline of cystic changes, denoting small dilatations with infection. Recurrent cholangitis. What is this? C-called big or large gallbladder with pericholecystic edema, and C-called gallbladder, and here appears as enhancing because of the inflammatory process. So the inflammatory process causes this hypoechoic area, and it is too much thick for fluid only. This is heterogeneous, denoting inflammatory changes. Cholecystitis with pericholecystic abscess. In acute cholecystitis, the most sensitive findings are inflammation and significant thickening more than 3 mm of the wall, with increased attenuation in the setting of a distended gallbladder. So you have distended gallbladder and you have thickened wall. Transit focal areas of increased attenuation in the liver may be seen, denoting inflamed gallbladder, denoting hepatitis or hepatic, indicating hepatic arterial hyperemia and early venous drainage. Other findings include presence of the pericholecystic fat, pericholecystic fluid, stranding, and increased attenuation of the bile are also noted. These are signs of acute cholecystitis. Here we have gallbladder with masses and transverse fold and several gallstones. This is dilated common bile duct. This is dilated pancreatic duct. That means there is obstruction in this area. The pancreatic duct and the common bile duct are dilated due to carcinoma of the pancreas, but this is another finding. This is adenomyomatosis of the gallbladder. Septum, gallstones, thickening of the wall, nodularities if there. This is a gangrenous gallbladder with a stent. Catheter is put in place to drain. common bile duct papilloma. This is the one. This one is the common bile duct. This one is the cystic duct, and this is the gallbladder. Mesenchymal hamartomy. This is another process involving the mesentery with cystic changes. This is an intrahepatic cholangiocarcinoma of one of the biliary radicals. It's called peripheral cholangiocarcinoma, which is obscured by the left lobe duct. Resulting in a cavity which looks like an abscess. This is the dilated duct, and this is the cavitary lesion, and this is the one. Multiple stones in the dilated duct. There are multiple stones as well. So there is a question we should answer, that if you find dilated biliary radicals or dilated common bile duct with stones, think of distal obstruction. So here there was an obstruction due to abscess and due to carcinoma, and then we have the abscess formation here. And this one, we have the tumor within the left main, right main duct with obstruction and dilatation of these biliary radicals, and of course heterogeneous mass at the region. Cholangiocarcinoma with dilated biliary radicals, cholangiocarcinoma with abscess formation. Dilated left branches, dilated right branches, nothing around here, no common bile duct. This is typical appearance of clad skin. Dilated left, dilated right, and no continuation, clad skin. Hypodense tumor, hypodense tumor with a catheter seen here to drain. These are different hilar cholangiocarcinoma, different appearances. It is on the undersurface of the liver, undersurface of the liver, and it's called clad skin tumor. It may be completely obstructed like this too, may be partially obstructed like mainly left lobe here, and the right lobe is little bit involved, but mainly left. Cholangiocarcinomas, you have the shouldering, you have the rat tail appearance, you have the marked dilatation above. Cholangiocarcinoma is a mid-extrahepatic duct, at the middle of the extrahepatic duct. The common bile, the common hepatic, the left, the right, all are dilated. Primary papillary adenocarcinoma, this is a double duct sign, dilated pancreatic duct, dilated common bile duct. This is dilated common bile duct, and here is the drainage tube coming percutaneously into the common hepatic duct. Rat tail appearance with shouldering due to denoting malignant obstruction of the common bile duct, but here it is due to para-aortic lymph nodes. And of course, such an appearance should raise the possibility of cholangiocarcinoma and pancreatic head carcinoma. You have three possibilities: lymph nodes, here it is lymph nodes. Another possibility is the pancreatic carcinoma. A third possibility is the cholangiocarcinoma. Hepatic duct obstruction secondary to metastatic gallbladder carcinoma, again giving shouldering and rat tail with marked dilatation above. The cause may be pancreatic, the cause may be cholangio, the cause may be lymph nodes, and the cause may be also metastasis in the region nearby due to nearby organ carcinoma like the gallbladder. Metastatic obstruction gives the same appearance as if any malignant obstruction. It is abrupt with shouldering, rat tail, with displacement, with ironing and stretching of the tubes, obstruction, attenuation. These are metastatic metastatic lymph nodes or metastatic masses around. Metastatic versus papillary. Here we have fistulation because there is a stent here going out from this, and there is some perforation happened here, resulting in dilatation of the pelvic cell system with filling instantaneous with the contrast seen in the common bile duct. Papillary carcinoma with common bile duct or metastatic lymph nodes or pancreatic carcinoma all can give the same appearance. This is mainly left lobar, but if you look carefully, the common bile duct is dilated and with multiple filling defects inside and multiple stones around. So this is an intraductal papillary carcinoma. Here it is, this one. This is the one, intraductal papillary mass, and this is the dilated common bile duct above. A stone can give this appearance. This is what we call meniscus sign, and a stone can occur on a metal encasing a metal clips as a labculi, and here we have multiple stones along the common bile duct which is dilated. So de novo on top of clips and with sludge formation in the common bile duct post-operative. Post-operative, again, post-operative dilatation of the right hepatic, left hepatic, and part of the hepatic duct here, but the common bile duct is not seen. It's only part of the intestine which is anastomosed, because this is in repair of either a tumor at the common bile duct or an injury during labculi. This is colidico-jejunostomy. Now what are these? We have the multiple gathered together cystic changes with ill-defined margins and ill-defined thick partitions in between, and this is the typical appearance of abscess formation. Thank you.